rapid access to comprehensive oncology data and survival analysis. This is the Oncotoolkit.
You know how it is in a busy clinic. Every single second counts. Accurately stratifying thrombosis risk in essential thrombocythemia? That means juggling multiple complex guidelines, and that's time you just don't have. So what if you could compress that entire evidence-based workflow into, well, less than a second?
This right here is the core promise. Instant stratification that leads to streamlined, rock-solid, evidence-based decisions. We're talking about automating a really complex, multivariable risk assessment, one that's absolutely critical for patient outcomes in ETG, and doing it all in the time it takes you to click a button. Now, to really appreciate the power of this automation, we first have to break down the clinical challenge it was built to solve. Let's dive into understanding the core thrombotic risk in essential thrombocythemia.
Okay, let's start with the fundamentals. Essential thrombocythemia, or ET, is a BCR-ABL1 negative myeloproliferative neoplasm. And really, what that means is we're looking at two key pathological features: clonal thrombocytosis, that's an uncontrolled overproduction of platelets, and megakaryocyte hyperplasia right there in the bone marrow. And this slide, this is fantastic. It shows us the molecular engine that's actually driving the disease. You can see the key mutually exclusive driver mutations right here: JAK2, CALR, and MPL. These mutations, they essentially flip a switch to be on position, and it gets stuck there. This causes this constant constitutive activation of hemopoietic signaling pathways like JAK-STAT, and that's what leads to the uncontrolled production of platelets. And hey, keep your eye on that JAK2 V617F mutation. It is going to be a critical player in our risk stratification.
So, here's the bottom line for us in the clinic. Our patients with ET can live for decades, which is great news, but that long life is constantly under threat from the #1 danger of this disease: a high risk of life-altering blood clots. These vascular events are the leading cause of morbidity and mortality, period. So our most important job is to rigorously and accurately stratify that thrombosis risk to guide our therapy.
So how do we actually quantify this risk? Well, that brings us to the scientific foundation, starting with the landmark 2012 model, the original IPSET-Thrombosis score. This table breaks down that original point-based model from Barbaoui and his colleagues. It's a really smart weighted system based on hazard ratios. Age and cardiovascular risk factors, they each had 1 point. But look at the heavy hitters: a history of thrombosis and that JAK2 mutation we talked about, they each add a full 2 points. The data is clear. These two factors have the strongest predictive power for future clots.
And here's how those points translate into actionable clinical data. A score of 0 to 1 puts a patient in a low-risk category, right around a 1% annual risk. A score of 2? That more than doubles the risk to 2.35% per year. And a score of 3 or more puts a patient squarely in the high-risk category at over 3.5% per year. This objective quantification was a huge leap forward. It gave us a much, much clearer picture than the older systems.
But of course, clinical science never stands still, right? This led to the next evolution of the model, which was all about getting even greater precision, especially at the lower end of the risk spectrum. And that is the Revised IPSET-Thrombosis, or R-IPSET.
This side-by-side comparison is perfect for seeing what changed. The original IPSET had 3 tiers. The revision expands that to 4. The biggest changes? Well, cardiovascular risk factors are removed from the primary score, and we move from that point-based system to a direct categorical logic. The goal was to get much more precise, specifically to identify that very low-risk group of patients who might not need aggressive therapy at all.
And here is that categorical logic in action. It's just a clean, efficient decision tree. Think of it like this. Is your patient under 60, no prior clot, and JAK2 wild type? Very low risk. Same patient, but they have the JAK2 mutation? Now they're low risk. Okay, what if they're over 60, no prior clot, JAK2 wild type? That's intermediate risk. And high risk? That's simple. Anyone with a prior clot, period. Or someone who is both over 60 and has the JAK2 mutation.
Now here's the payoff for that refined logic. Just look at the granularity this gives us. The very low-risk group has an annual thrombosis risk of just about 0.5%. The model successfully carves out this much safer population. And you can see that clear, stepwise increase in risk through the low and intermediate tiers. It really demonstrates the superior discriminatory power of this revised model.
Okay, so we've gone through the pretty complex science. Now let's see how Oncotoolkit just masters all of this, delivering instant, reliable risk stratification right at the point of care.
Step 1 is exactly as simple as it looks on screen. You just input the 4 key variables we've been discussing this whole time. The interface is clean, it's simple, and it's built for speed.
And the moment you hit enter, bam, you get this, an instant dual model output. You're not just getting one score, you're getting both the original and the revised IPSET calculations at the same time. For this patient, you can see immediately they are high risk by both models, with the exact point score and the annual risk percentages clearly displayed. This isn't just data, this is an immediately actionable clinical insight.
Okay, so step 3 is the so what part, translating that output into action. Based on NCCN guidelines, a high-risk result means cytoreductive therapy is mandatory. The tool doesn't just give you a number, it connects you directly to the standard of care.
You know, for any digital clinical tool, trust isn't just optional, it's everything. And that brings us to a core design principle here: total validation and transparency. This is the anti-black box.
And this is where the show logic feature comes in. With a single click, the app just reveals the exact calculations and logical steps it used to get to its conclusion. This ensures 100% transparency. You can see precisely how the points were assigned for the original model and exactly how the categorical logic was applied for the revised version. This is how you build complete clinical trust.
And this is so important. This connects the entire framework back to the primary source literature. This quote from Barbeau and Teferi really underscores the whole mission: to provide management recommendations based on these massive studies. The tool isn't inventing a new standard of care. It is a high-fidelity digital implementation of foundational peer-reviewed research.
All right, let's pull back for a second and think about the broader impact here, moving beyond a single patient in the clinic and into the world of research. This is a really powerful concept. The tool includes functionality to securely export anonymized patient variable data. And to be clear, this is not for EMR integration. This is a bridge to deeper research. It allows institutions to easily facilitate cohort analysis for their own internal research projects, to accelerate the study of treatment responses and outcomes, and ultimately to link our routine clinical practice directly to the advancement of hematologic science itself.
So I'll just leave you with this thought. If we can make complex, evidence-based risk stratification truly instant, freeing up our time and our cognitive load, what's the next clinical challenge we're going to automate? The potential is just enormous.